Hello friends, today we are going to discuss about infection in the immunocompromised host. So these two types of the immunocompromised host we are discussing here, that is post-organ transplantation and HIV infection. So the population of the patient receiving organ transplant to restore the vital organ function and prolong life continues to grow. So immunosuppressive regimen that suppress T cell immune function and are employed to prevent organ rejection and maintain long-term allograft function. The immunosuppressive regimen employed in all forms of organ transplantation are similar, with cyclosporin or tacrolimus providing the cornerstone of maintenance anti-rejection treatment, along with antimetabolites such as MMF and possibly low-dose corticosteroid. Hence, these type, pattern, and timetable of the infection encountered are similar in all form of organ transplantation. The risk of infection is primarily determined by the intensity of exposure to potential pathogen and patient's net state of immunosuppression. The main determinant of the net state of immunosuppression are dose duration and the temporal sequence of immunosuppressive agent and the presence or absence of infection with immunomodulating virus like CMV, EBV, hepatitis B, C, and HIV. The infectious risk encountered by the organ transplant recipient can be divided into three phases. The first month after transplantation, 1 to 6 months after transplantation, greater than 6 months after transplantation. These phases are determined by the degree of immunosuppression expected during this time period. These phases are dynamic and can be altered by the routine antimicrobial prophylaxis for pneumocystis, CMV, hepatitis B virus, and by the requirement to change or intensify immunosuppressive therapy for prevention or treatment of rejection. So first month after transplantation, the consequences of immunosuppressive therapy have not yet taken if therefore there is usually notable absence of opportunistic infection during this time. So infections present in the allograft recipient prior to transplantation, infections transmitted via concomitant allograft, and infection encountered in the post-operative setting are encountered. Undetected and incompletely treated infection occurring in the pre-transplant setting may manifest or exacerbate in the first month after transplantation. Pneumonia and the bloodstream infection related to the vascular access device are common in the pre-transplant recipient. So infection specific to the different transplant organ may occur. For example, peritonitis in patient who receive liver transplant for end-stage liver disease. Infection transmitted on contaminated allograft are rare, but they do occur and frequent among lung transplant recipients. These allograft transmitted infection are usually caused by the variety of bacteria from donor who was not known to be bacteremic at the time of organ harvest. Most unusual viral infections such as rabies, lymphocytic choriomeningitic virus, West Nile virus have been transmitted via transplanted organ. Transmission of tuberculosis, Trypanosoma cruzi, and the T. gondii have been reported with higher incidence in the areas of endemicity. To prevent transmission of infection via allograft, extensive screening of donor is performed and it includes blood, urine, sputum culture, serological test for HIV, HTLV, CMV, hepatitis C, hepatitis B, EBV, VZV, toxoplasma, purified protein derivative skin testing, and Trypanosoma cruzi serology for donor from the area of endemicity. The majority, that is more than 90% of infection encountered into the first month after transplant are those related to surgical procedure and are same as those that occur in the other post-operative patient. These infections result from the breakdown of normal mucocutaneous barrier and presence of devitalized tissue and fluid collection at operative state. Bacterial and candidal infection of surgical wound, pneumonia, urinary tract infection, and infections related to vascular access device, stent, and drainage catheter are very common. Any type of the leak related to the surgical procedure that may that may form biloma, urinoma, seroma, lymphocele, and hematoma can readily become secondarily infected with bacteria or candida in post-transplant setting. Then 1 to 6 months after transplantation. A period from 1 to 6 months after transplantation is critical time period after transplantation during which infection unique to these immunocompromised hosts most often arise. During this time period, the depth of immunosuppression is at its greatest and may be further enhanced by the presence of infection with immunomodulating virus. CMV is the key player among these viruses and have been demonstrated to have multiple mechanisms by which it can induce further immunosuppression. Other herpes virus include such as EBV, HHV6, HHV7, HBV, and HCV, HIV, if present, are also immunomodulated. The cellular immune system is the primary arm of host defense that is impaired. Therefore, these patients acquire opportunistic infection that require intact cell-mediated immune response to prevent and control the infection. So CMA is the most common, most important opportunistic infection occurring in the organ transplant population, given its direct and indirect effect on the organ transplant recipient. So direct effect include clinical manifestation of the CMV infection, such as viremia, that is often accompanied by the CMV syndrome, or candid or end organ disease such as gastritis, colitis, pneumonitis, and hepatitis. Indirect effect of the CMV infection include viruses' ability to modulate immune system, contributing to the net state of immunosuppression and its contribution to oncogenesis, its role in the allograft injury and rejection. Other herpes virus such as varicella zoster virus can reactivate and present as Shigella and disseminated infection. Parvovirus B19 can be acquired by usual respiratory route or from the transplanted organ or the virus that can reactivate from the latent state. The most common manifestation of parvovirus B19 infection in renal transplant recipient are anemia and reticulocytopenia and pancytopenia. Intracellular bacterial pathogens such as nocardia, listeria, legionella, tuberculosis can cause infection during this time period. In addition, patients are susceptible to infection with invasive molds such as aspergillus and later in this time period to infection with cryptococcus and with geographically restricted endemic mycosis, histoplasma capsulatum, coccidioides immitis, and plastomycosis dermatitis. Patients are at risk of infection with pneumocystis jirovecii, but this risk is minimized by antibiotic prophylaxis. The occurrence of parasitic infection like strongyloidosis, toxoplasma, leishmaniasis, and trypanosomiasis depends on prior exposure of donor or recipient to this pathogen in the endemic area. The polyomavirus BKNJC may reactivate during this time, causing nephropathy, particularly in the renal transplant recipient, and PML in any of the organ transplant recipient. Respiratory viral infections such as influenza, RSV, parainfluenza, adenovirus can cause serious infection in organ transplant recipients. Infection often at this time caused by antibiotic resistant bacteria such as vancomycin resistant enterococci, methicillin resistant staphylococcus aureus, and gram negative rot. Azole resistant candida species which linger on the early postoperative period in the setting of persistent drains and catheters. Now, infection in more than 6 months after transplantation. The susceptibility to the infection in this time period after transplantation depend on the presence or absence of well-functioning allograft and or chronic and progressive infection with CMV, EBV, and hepatitis virus B and C. Patient with the well-functioning allograft or minimal maintenance immunosuppressive therapy, they are at risk for the usual community-acquired infection, primarily respiratory infection. Patient maintained on the high doses of immunosuppressive agent because of the recurrent and the chronic rejection remains at the risk of opportunistic infection with pathogen described above. This patient chronically infected with immunomodulating viruses remains at significant risk for secondary infection as well as for the viruses associated malignancy. Those infected with hepatitis C and B viruses, they are at risk for hepatocellular carcinoma. Chronic Epstein-Barr virus infection can result in uh, PTLD with its protein indolent or fulminant manifestation. Papillomavirus infection can result in squamous cell carcinoma of the skin that may be difficult to control and treat, resulting in metastasis and significant morbidity and mortality. So this is the timeline. This diagram is representative of the timeline of the infection. So in the first 1 month, the infection, most common infection is the HSV, hepatitis B, C, and Candida. From 1 to 6 months, cytomegalovirus, Epstein-Barr virus, influenza virus, RSV virus, adenovirus, and polyomavirus. Then in fungus, nocardia, listeria, tuberculosis, pneumocystis cerevisiae, aspergillosis. Then strongyloids, leishmania, strongyloids, toxoplasma, trypsonema cruzi. Then we'll see the infection which are common in the HIV patient or in acquired immunodeficiency disease. Infection with the HIV causes chronic progressive immunodeficiency. Initially, it was thought that this immunodeficiency arose from the exclusive infection of CD4 T cell lymphocyte and subsequent cell death, resulting into the significant CD4 T cell depletion. However, with time, it was discovered that this virus is capable of infecting range of cell, including monocyte, follicular dendritic cell, epidermal Langerhans cell, alveolar macrophages, and the cell within the central nervous system. In early stage of infection, the high rate of viral replication in CD4 T cell results in major increase in daily production of CD4 cell that is balanced by the similar rate of CD4 cell destruction. Over time, gradual decrease in the cellular and humoral immune function occurs. Investigators have characterized wide array of functional abnormalities of immune system that accompany this decline in the CD4 T cell count. These abnormalities include decrease in responsiveness to mitogen and antigen, decreased proliferative response to certain pathogen, decreased cytotoxic or natural killer cell activity, decreased humoral immune response, and in concert, this abnormality produces state of general activation and disordered regulation of cellular and humoral immune response. A unique example of dysregulation of immune response is in HIV patient is immune reconstitutional inflammatory syndrome. This syndrome occurs in patients with AIDS, usually CD4 count of less than 100, who have pre-existing infectious process that worsen paradoxically after initiation of highly active antiretroviral therapy. The immune reconstitutional inflammatory syndrome have been more frequently reported with herpes zoster, Mycobacterium tuberculosis, Mycobacterium avium complex, CMV, and Cryptococcus infection. The immune reconstitution inflammatory syndrome likely arise from interaction of exuberant and recovering immune response following highly active antiretroviral therapy with residual antigenic burden and whose genetic susceptibility to such a process. Characteristics like primary infection with seroconversion, clinical latency, and early symptomatic disease, and acquired immunodeficiency syndrome. The infectious complications that occur in patients infected with HIV-1 correlate with the level of CD4 count. After resolution of primary infection, patient enter the phase of clinical latency when they are primarily asymptomatic if peripheral CD4 count remains above 500. If CD4 count declines to 500, patient begin to develop constitutional symptoms. These symptoms often accompanied by the infections caused by reactivation of herpes virus such as herpes zoster virus, herpes simplex virus, Epstein-Barr virus, or oral mucosal infection caused by candida. Additional infectious complications that occur when CD4 ranges from 200 to 500 include pneumonia caused by pneumococci and other bacteria, reactivation of pulmonary tuberculosis, cervical or anal dysplasia, or cancer attributed to the human papillomavirus. Other less common symptoms syndrome that occur during this time and are associated with viral reactivation include EBV associated B cell lymphoma and HHV8 associated with Kaposi sarcoma. Late stage disease and HIV defining state occur when CD4 count less than 200. The median time from the onset of this severe immunosuppression to AIDS defining diagnosis is 12 to 18 months in person not receiving antiviral therapy. This phase is characterized by the development of opportunistic infection, tumor, wasting, and neurological complications. The most common opportunistic infection encountered in this time period, in the absence of antibiotic prophylaxis, is pneumonia caused by Pneumocystis jirovecii. Disseminated endemic mycosis such as histoplasmosis, coccidiomycosis, and extrapulmonary tuberculosis are encountered. PML caused by reactivation of polyomavirus and JC is less common diagnosis. With further decline in CD4 count, a broader array of opportunistic infection can occur. CD4 count below 100 is associated with toxoplasmosis encephalitis, cryptococcal meningitis, candidal esophagitis, chronic diarrheal disease associated caused by cryptosporidium or microsporidia, and disseminated HSV infection. Disseminated MABM complex and CMV infection are two main opportunistic infections usually encountered with severe immunosuppression when CD4 count falls below 50. The function of T lymphocyte and risk of opportunistic infection decrease with reduction of viremia by antiretroviral therapy even when CD4 counts are not restored or not. Thank you guys.